Good afternoon, students. This is Miss Bennett, and this is your tissue integrity vid grid. This is your final lecture. So I really tried to get the majority of the content in this vid grid for you guys. So that way we can just slightly touch on some material in class. So let's go ahead and get started. Okay, so this is in your Pearson text, does start on module 21. So the concept of tissue integrity, the definition does include the ability of a body's tissue to regenerate or repair to maintain the normal physiological process. This does include our skin, hair, nails, sweat, sebaceous, and mammary glands. There are obviously three main layers of our skin. This does include that epidermis, the dermis, and then the subcutaneous tissue. So that figure is also in that Pearson text on, shoot, I forgot to write the page number, but it is figure 21.1. I tried to put a little bit better illustration on this first slide, but I'm not going to be testing you guys if you know your layers like A&P would, but you have to be able to describe wounds as you guys become a nurse. And then, of course, for the NCLEX and next gen style questions, don't be surprised if we are using this terminology to describe a wound or where you would expect a wound to be, like a certain stage of healing according to these areas, the layers of the skin. So definitely be familiar with those main areas there. So we flip back to that other slide. Obviously, within the skin, we do have something called keratin that does help repel water that is more majority on the surface of our skin. And then melanin, of course, also does protect us from the UV rays. And then another helpful quick tip on melanin that your book definitely went in a little bit deeper. Those with obviously less melanin, they have lighter skin tones. More melanin, those are darker skinned individuals. Of course, the darkest skin tones are usually from individuals that either came from a hot climate, or possibly ancestors or cultural lines of getting that passed down. So there are also epithelial cells that cover all internal and external body surfaces. Those skin tissues, basically those cells, their function does include protection, absorption. That includes that vitamin D. That's why we really, especially as we get older, and I'll just say it, white Americans, we are very low in our vitamin D because we just aren't out in the sun like we used to be when we were kids, and we're of course not taking in the vitamin D like we should with our dairy or milk products. Our skin cells also are part of our thermoregulation system, that is through secretion of our sweat, and then excretion when we have an abundance of things like electrolytes or urea. That's how our body helps get rid of some of that waste. One other thing I want to talk about is something when we have too much. Oh my goodness, sorry, my notes, I just realized say melatonin. We're talking about melanin. So when we have too much melanin in our skin, that does cause something called melasma. This is often identified as gray or brown discolored patches on our face or other skin exposure locations. That can be very common as we get older. There are a lot of people call them like brown spots, age spots. You'll notice some more like on the cheeks. And it's just basically a cluster of that melanin that has kind of, where maybe an individual was in the sun quite a bit when they were younger in one like low localized area. It is often on like our cheekbone area, it seems to be for some individuals. So that is just a process of where that melanin does seem to concentrate a little more heavily in those spots. And that's why we get those, we call them age spots, brown spots. That's what that's from. especially on our face. Okay, so some classification of skin disorders. I'm not going to make you guys have all of these memorized. Of course, this does begin on page 1612. I did go through here in a second. I'll show you. I went through and highlighted the main boxes. You guys are going to be like, Miss Bennett, you did everything but two. Well, it's because most of those we've already covered some pain, obviously. But just definitely be aware of these different acute and chronic. Obviously, acute means that the skin condition or infection is very short-lived. Chronic definitely means that it's going to be lingering on. So it's going to not get over in a couple weeks. It can sometimes be a chronic issue where people have it for life, or it can be something that can take several months or maybe even a year to completely get over. Some of those different alteration types, of course, include our infectious diseases. That does include our fungal, bacterial, viral, or parasite. Then there is, of course, inflammatory processes that can happen to our skin. This can occur with pathogens, acne, burns, eczema, dermatitis, psoriasis, anything that would cause like that inflammation, allergies, anything like that could inflame. It's just how our body's responding to these, I guess you'd call them pathogens, as well as neoplastic. That, of course, is our skin cancer. I'm not going to go in real deep. I'm just trying to introduce some of these areas to you guys. You guys will hit on some of these a little bit further on as you guys go through your different levels, but those are just those are the main types, either acute or chronic, and then of course infectious, inflammatory, or neoplastic. So within our skin disorders, we also have wounds. They can be intentional, which means that we've actually caused the wound on purpose, such as like surgery, or a venipuncture is the example the book gave. So like if we've actually purposely caused the break in the skin, it is called an intentional wound. And then, of course, there is unintentional. This is obviously something accidental. The best example that they're coming up with that the book mentioned is, of course, the compound fracture. So if you guys are tying in some of that information from that fracture material, obviously that compound fracture is when the fracture can break the skin. And so that's just one example. Of course, we can have unintentional wounds or trauma to our skin as a result of any kind of trauma or force, right? So it could be a paper cut. It could be cutting your finger when you're chopping up vegetables. So just definitely kind of keep that in mind. Of course, there's what we call closed wounds. When you guys are thinking of a closed wound, I want you to kind of think of a really bad bruise, or the book actually refers to it as a hematoma. So this is trauma that has occurred to the tissues within the skin, and it obviously is causing some sort of breakdown, either is in the capillaries or there is some bleeding, maybe some swelling. It can be sore, painful, and that's definitely what we call a hematoma. Sometimes hematomas are small enough that we just watch them and there's no concern. When we do get concerned is when it starts affecting our lab work. Maybe we are having some drop values in our blood counts, or maybe the size of that hematoma is so large that our kidneys are even struggling with reabsorbing that trauma, or just sometimes that trauma response can affect our kidneys as well. So because of my background in cardiology, hematomas were definitely something that we had to really watch for post heart cath patients, anything like that, where we're going through those really large groin arteries, like that femoral artery. We are worried about that artery obviously not closing off or oozing to cause that hematoma. It can happen, of course. That is definitely one of those first things that we're going to watch for. And then even the patients that have the outpatient, like a heart cath, we definitely have to educate them quite a lot. They can't do anything real strenuous after they've had those heart caths, because any type of strenuous, I remember having a lady that she came in for a heart cath, I want to say it was like the week of Thanksgiving, and then went out to Black Friday shopping, and then ended up back in our office that that afternoon from the morning of Black Friday, and huge hematoma just from her overexerting herself and probably carrying packages or whatever items around, and it just was too much. And so she had a really, really large hematoma that they actually had to go in and surgically get it drained and kind of go from there. So a hematoma can obviously lead to some more significant issues. Just be aware when we are talking about a hematoma, it is considered a closed wound because there may not necessarily be an opening. And then an open wound, of course, is any kind of break within our skin, mucous membrane, any kind of surface break. Now, of course, when we are talking about wounds, especially as nurses, our biggest concern is infection, right? So there are obviously some degrees of infection risk or contamination. So we consider clean wound means that more than likely a clean wound is something that hopefully we have created, like an intentional wound, like in a surgical area. And we consider those clean because obviously our surgical area is sterile, and hopefully that is without any kind of contamination. Now, we can have a clean, contaminated wound. You can think of maybe a child falling and scratching their knee open. So it's technically a clean wound in the fact that hopefully their skin was clean before they fell and scraped up that knee. But then we do consider it contaminated now because it was not done in a sterile environment. So now they've obviously have some debris, things like that inside that wound that usually our biggest concern is getting that cleaned off. And that's why I don't know if you guys remember as kids and definitely as a parent, those are those first things you do is just get them cleaned up. And get that wound or area kind of cleaned up. And usually for the most part, scratches, scrapes, things pretty mild can usually heal on their own for the most part. Contaminated wounds, of course, this does get more advanced. That's when we actually know that there is something that's gotten inside the wound. Let's say it was originally a surgical wound, and then we find out that we got a bacteria in there, and now it's growing. Some issues there. Of course, there is also even worse, some dirty or infected wounds. I always think of, unfortunately, the homeless population. It actually can be anybody that just is not achieving that proper hygiene and care for themselves, but it can just be someone that's in an environment that is not very clean. They cut themselves or hurt themselves in some way that have a trauma to their skin tissue, and then of course that does lead to a very infected wound and so forth. Okay, so this is these tables, they start on 1612 to 1613. These highlighted areas, all of these, definitely know these terms, be able to recognize them. So when you guys are seeing them in these scenario questions, you're not like, what is she talking about? Definitely edema. That's a huge thing that we will dive a little bit deeper in just a second, but definitely know what inflammation means, how we treat them. Really focus on these interventions and treatments for each one of these. Obviously, there's pruritus, that is that itching that we can often get. It can be from a reaction, like a systemic reaction, like an allergy, or it can be something from the infection itself causing the itching. We'll talk a little bit about some pruritus symptoms when we talk about head lice here in just a second. And then definitely be familiar with the word exudate. In order to be able to identify when exudate is a problem, we have to be able to know, of course, what it is. So this is some fluid from a wound. There can be what we call good exudate, and then the exudate that we start worrying about is leading to an infection, and that's obviously purulent drainage. We'll dive a little bit deeper when I get to the wound healing exemplar here in just a second, but definitely be familiar with these interventions, what those signs and symptoms look like for each of these vocabulary words is what I'm going to call them. I don't know what else to call them for you guys. And then, of course, there is bruising as well. Okay, so know those highlighted boxes, especially the interventions and treatment. Okay, so as a nurse at the bedside, it can actually be even in a clinic or facility, because that's honestly, I actually saw probably more wounds walking in with the patients that were coming into their primary care provider than I probably actually took care of on the cardiac floor, just because that's just where I was at. We didn't see a whole lot of wounds, obviously, when I was working in cardiology, unless they were related to the patient that was having cardiac problems. So when I ended up working for a primary care provider for several years, people would be coming in from their homes, from off the street, with lots of wounds. And so that's probably where I got most of my wound experiences in primary care, actually. But anyway, so our role as a nurse, of course, is to assess the wounds and any sort of ulcers. We need to be able to identify, is this an acute problem or is this something chronic? Obviously, that is getting a really good history. So we find out that this person did something months ago, I would definitely say that this is kind of turning into a chronic issue. If this is something that just suddenly happened, of course, that's an acute injury or wound. We have to be able to be very descriptive. So we need to be able to tell where the wound is, our size, length, width, the depth of the wound. Some other important vocabulary words I'll dive a little bit deeper into in just a second is partial versus full thickness. You'll definitely need to know those differences between partial and full thickness in what's important with each one of those. Of course, there's the color of the skin and the surrounding tissue. Is it red, yellow? Is it necrotic or black? Obviously, cleanliness, cleaned or contaminated. Does it have an odor? Is there any sort of wound drains? Any kind of types of drains? I'm not expecting you guys to know every sort of drain type at this level, but just definitely be aware. Some of you have been able to see some patients in clinicals. I've had a couple drains in. There's obviously all sorts of drains that are out there. So just definitely as you guys are going through the clinical process, as you guys advance in your levels, just definitely be aware of the drains and what's important when we have a patient with drains, whether it's from a wound, chest tube, whatever it is. Really being accurate with our output is the biggest thing that I can tell you. You need to know whatever your protocols are for that unit, that area. When should you be marking the containers, emptying them? When do you need to call the physician to let them know the amount of drainage that you're seeing, those type of issues. Obviously, there is, kind of I was talking about earlier, that exudate. So it can be either serous, sanguinous, and then purulent. And so we'll dive a little deeper into just one more slide there. I've got some pictures of examples of each one of those exudates. And then, of course, there is staging of wound ulcers. That will be part of our exemplar towards the end of this vid grid in just a little bit. And then we need to obviously observe for progression of healing. That does include sometimes removing those dressings. There are, of course, are certain protocols straight out of surgery, things like that, in certain ICU areas where the actual surgeon usually will want to be the first person to remove that dressing, unless we're having issues where we're having bleeding that's soaking through the dressing. Just be very aware of dressings, when they were changed, their date, the time that they were changed, and then how is that looking? Are we worried that we are having bleeding issues and it's bleeding through the dressing? Or when we remove the dressing, are we having issues with purulent drainage, signs of infection, redness, things like that? So, of course, as a nurse, we are the eyes at the bedside for that physician often, or the healthcare team in general. So wounds, ulcers should be located and described as soon as you receive that report or are admitting that patient to the floor. That is probably the biggest thing I will tell you guys. I know probably Monterey hopefully mentioned a lot of this when she went over assessment data with you guys in the skills class, but you've got to really look at that individual's entire body, identify those wounds, so that way, if for some reason they came in with something, we will know it's already there. And so that way, if a wound were to develop afterwards, pressure ulcers, things like that, insurance companies are starting to penalize us in the hospital setting. So we just definitely need to be aware what their skin was, how their skin was it intact, were there wounds ahead of time, even surgical things. We just have to really be aware, and that should be a huge priority next to, assessing your major body systems, your breathing, circulation. We've got to look at that skin, and if they have something wrong in those areas, we've got to get it documented right away, so that way we can see a progression, whether it is healing or getting worse, and then what we're doing to support that patient in those incidents. Obviously, when we are this baseline assessment of their skin will allow healthcare team to evaluate that skin's healing process, and then when describing wounds and ulcers, we need to be extremely descriptive. So part of being descriptive is using what I call wound descriptors. So when we're talking about a partial thickness wound, this is a very superficial wound. This can obviously involve that epidermis. So let me flip back over to that first slide. So this is more like that first layer of skin when I'm talking about a partial thickness wound. This is often like an abrasion, scratch, maybe a blister that's just very, very small. The very top layers of the skin. A full thickness, of course, is a deeper wound that does extend through all the layers of the skin. It can include the subcutaneous tissue and can spread to the surrounding muscle, tendons, and bones, depending on the stage of it. So let me flip back over to where that picture of that skin is. So this a full thickness, of course, is all the layers of the skin, including that subcutaneous, and then even deeper into the muscle, tendons, and then the bones. So then when we're talking about that exudate, this is when we have to really be able to use these descriptive words. And hopefully you guys have come across maybe wound care notes, or maybe hopefully the physicians have been good about describing wounds or things like that on the patients we've seen in the clinical setting. But when we're talking about a serous drainage, that is that clear, thin, watery drainage. And then if we have serosanguinous drainage, that is that clearish fluid, but it is mixed with blood. So as you can see, it's kind of like just a light pink colored. Both of these are not concerning. Serous is actually a normal sign of healing. And serosanguinous, it can be expected with some surgical incisions, of course, because we've had some trauma. So some bleeding or pink hue is okay. When we do start getting worried is when we maybe see some sanguinous drainage that is mostly blood. Now, if it's not soaking through dressings, or if it's just maybe on the bandage when you take the bandage off, that's usually okay. But as long as we're not having an excessive amount or uncontrollable bleeding, then we would obviously worry. And then, of course, if it's soaking through, there, of course, will be protocols a physician will say. If it soaks through within 30 minutes, I need to know, or maybe an hour, whatever their protocols are in place in some surgical areas. And then that purulent, of course, this can be some different hues or colors to it. I've seen some purulent drainage that did have a little bit of a green or yellow tint to it. I've seen it where it was like that milky white or gray color. It, of course, is often pus-like, and sometimes it has some odor to it as well. So that's what we consider an infection of the skin, is that purulent drainage. Okay, so let's talk about some lesions. So I'm not going to make you guys know the primary lesions, just because those, honestly, from a nurse standpoint, unless you're going into dermatology, those are usually part of that physician's role, or maybe even nurse practitioner's role, that are diagnosing those primary lesions. I mostly want us to be aware of the secondary lesions. So be aware of these definitions. So this is found on page 1615. It is table 21.2. So let's start with this first one. So scales, that is that sheddy, flaky kind of skin. Sometimes it is a greasy tissue, depending on where it's located and the type of skin that we're seeing. It can often be white, grayish, or silver color. There can also be what we consider crust. This is obviously dried blood, serum, or pus on that skin surface. And then we have that linear crack, or that fissure. Anytime you guys see that word fissure, that just means there's been a hole of some kind. This is often sharp edges, can extend into that dermis area. So as you guys can see, it is past that epidermis area, and it is kind of going to that second layer of the skin. Then, of course, we have an ulcer. These are often deep, irregular shape, and they can extend into that dermis and subcutaneous tissue. Sorry, I've abbreviated subcu after a while. And then we've got the scar that is that irregular area of that connective tissue after a wound has healed. Often it is made up of some collagen, and it is usually a permanent thing. Depending on the person's skin tone, things like that, obviously scars are more noticeable than others. And then we've got atrophy, which is, of course, is our age skin, our geriatric population, where it becomes very thin. Another one to think of with that atrophy can sometimes be those neonatal preemie babies. Their skin is often very fragile. I actually have a scar on my right arm from when I was a preemie, and the way my dad describes my skin when I was first born, he said it was almost like peeling an onion, just one little slight touch, and my skin tore. And so I have like a little scar from it. It is obviously aged as I have, so it's not as noticeable. When I was little, I definitely noticed it a lot more. But just also think of anybody with that kind of fragile skin as that atrophy. Their skin is just so thin. Obviously, for a preemie, they just don't have a lot of meat on their bones, that adipose tissue to kind of help support their tissues, that surrounding tissue. So those skin lesions obviously can be divided up into that primary and secondary. So just be aware that the primary skin lesions do originate on previously healthy skin. They can directly be associated with a very specific cause. Examples are like a cyst, papule, macule, which is like a freckle, and then a vestibule, which is like a blister. And secondary skin lesions does happen from, they do usually occur from like those primary causes, either something hanging around for a long time, and then so let me give you an example real quick. So it's like that blister or vestibule. So if that vestibule breaks and there's some liquid that drains out, that could be more like the crust. Hopefully that's helping you guys understand that. Usually what ends up happening is we, as humans, we like to pick at things, right? So when we've picked at things like that blister, we can obviously burst it open, or we can cause some sort of traumatic manipulation or scratching or rubbing that can progress into these secondary lesions, of course. Some examples, of course, are like that crust area, any kind of sores, bed sores, ulcers, and then any kind of scars. Obviously, that can happen. Okay, so we're going to go into some nursing interventions, of course. So as our role when we're thinking of wounds and skin, what do we need to do besides assess the area and write a really good description? We obviously need to help control bleeding. If there is some bleeding, applying pressure, elevating that extremity if needed. Our goal is to hopefully prevent any type of infection. That is usually that, remember the story about when you have a kid that's skinned their knee, we need to get them inside, get that wound cleaned up. So we need to flush and cleanse that wound. At the bedside, we're often using something like normal saline. They do actually have some really good wound washes out right now. Those of you that were with me in clinicals, you may have seen some of the wound nurses come up, or wound care team is what I should probably be calling them, because they're not all nurses. They have obviously different specialties. So they even use what we call a wound wash for specific patients. We also need to sometimes keep that wound covered to help keep it clean. Sometimes it does involve a sterile dressing depending on where it's at. I'm thinking more of central lines, things like that, where we're really trying to keep that site nice and sterile, so that way we don't get an infection into the ports or into that central line area. We obviously need to monitor for any sort of internal bleeding. Or shock from our trauma patients. So we should also hopefully be promoting healing through proper hand hygiene, just educating our patients often. When should they go to the doctor? If it's starting to look infected, that's when they need to call their physician. There's so many times I've had patients that over the years, different procedures, different reasons why they had a wound or an incision, and they won't think to tell anybody, and then they'll come in for like a 2-week follow-up, and they'll be like, oh yeah, it's been like this for like over a week, and you're just like, oh my gosh, now it's like this massive tunneling wound, where if they could have just hopefully said something sooner, then we could have maybe got them the proper treatment, and then it wouldn't have been this full-on issue. So definitely education is huge here. Obviously nutritional support. We obviously need our protein, vitamin A and C, zinc, to help support any kind of tissue and wound healing. And then, of course, we are going to talk about today, or in class Monday, I'll show you guys what a wound vac is exactly. That is that vacuum-assisted closure of a wound. Those wound vacs, how they work is they do gently pull fluid from the wound over time with this sponge that is inside the base of the wound. This can help reduce swelling. It can help clean the wound and remove bacteria. And it also helps kind of pull in those edges. Unfortunately, anytime we've had to use a wound vac, I'll try to explain this a little better on the board Monday, but when we've had to use a wound vac, at that point, because of where the wound is, or maybe the edges of the wound isn't able to close. And so that's why we're having to bring that wound vac in, and we're having to heal the wound from the inside out at that point. And so that's where it helps, that suction. And then the sponge itself helps bring in the edges of that wound, so that way when it's suctioning, it is slowly bringing, supporting that granulation tissue, and hopefully that is, that tissue, that surrounding tissue is healing from the inside out. The wound vac itself does help stimulate the growth of new tissue and does help close that wound in the end. I have only probably seen maybe a couple times where, in fact, I think it was this semester even, with a group of students that we had a patient that actually had some complications from the wound vac. It ended up either was improperly put. I don't know her exact case, and I never, unfortunately, got to see her wound, but it was either improperly placed or maybe the suction was too high, but it ended up causing what we call a fistula, almost like a tunneling between her diaphragm and her abdomen wall there, and actually made the wound actually worse from where it originally was. So wound vacs are great, but you have to know what you're doing, and you just definitely have to really keep an eye on that tissue, and if it's not helping, then obviously those need to be taken care of and addressed right away. So what are some other common alterations? Another common alteration in our skin integrity does, of course, include edema. I don't know how deeply you guys covered edema in Miss Young's class or even Miss Monterey's skills, but just definitely be aware that obviously there are different stages of edema. And as you can see on this little picture, this is found in your guys' book on page 1632. It depends on how deep of an indention that when we are putting pressure on their extremities or wherever the edema is, how far deep does it leave that indent. So as you guys can see, there's slight pitting with that +1, then it goes to +2, which is a little bit deeper, and then +3, and then of course that +4 is pretty significant. So edema is from swelling due to accumulation of excess fluid under the skin and the spaces within our tissues. There's what we call peripheral edema. Think of that more our ankles, legs, and hands. Feet can be technically categorized with the peripheral edema, but most of the time when we're talking about feet, that is called pedal edema. Pedal edema, of course, can be just one foot, or it can obviously be both legs or both feet. Pitting edema, obviously when we're applying that pressure, that's what we're looking for. We're looking to see how deep of a depression it makes, and then how long does it last. Is it just for a split second? Then, okay, maybe it's a +1. Now, if it's like we're indenting and it is going about 8 millimeters, and then is it not rebounding, that's definitely a +4 pitting edema. Some other main common, I guess you'd call them disorders, skin disorders. Definitely be aware of candidus. This is on page 1616. This is just in the little chart that they have. I'm not making you guys know all of these diseases. You guys will get little bits of this throughout your nursing rotation. I'm just trying to point out just a couple of these. So this one is that candidus. It is on page 1616. This is a fungal infection caused by that Candida albicans. The other term for this is called thrush, as you can see in the back of this individual's mouth and tongue. That is that white coating on there. It obviously we can have Candida in other places. Besides our mouth, we can have it in our vaginal area, genital area. Actually, we can have it in any kind of like skin folds, things like that sometimes as well. This is often treated with anti-infungals, sexual abstinence if it is more of a genital or a vaginal area. They can use medications called nystatin or fluconazole. And then the biggest issue is hopefully once we get that treated, our biggest thing is to keep their skin in the area clean and dry. Obviously, if it's in our mouth, there are obviously different reasons why they're having the thrush. Sometimes it is a cause from something like maybe a weakened immune system, like I'm thinking of like an HIV patient, or even somebody that maybe is on quite extensive antibiotics, and maybe we've knocked out all the good flora in our mouth, and so maybe that's why we're having that candida in our mouth. So it's oftentimes some of the medications that we can give to people can be like an oral pill, like that fluconazole, or it can be like almost like a mouthwash, like this nystatin. We call it nystatin, like swish and swallow. Sometimes the physician will just have the patient spit it out. It just depends on how much he's giving them and what they're giving them exactly, but often it is like a mouth rinse that we will have patients swish in their mouth and then spit out. When I'm talking about the excessive moisture, we can't obviously control that in our mouth necessarily. That's more just treating the fungal infection and getting rid of it that way. But where I'm talking about other areas of skin, folds of skins, diaper rash areas, we've got to keep that skin clean, dry, and obviously excess moisture is our major risk factor. I would not be surprised if eventually, depending on the nurse's responsibilities and how well pericare is getting taken care of with some of these catheter alternatives, like the PureWick. I wouldn't be surprised if eventually we will start seeing, especially if I'm thinking like nursing home or maybe long-term rehab facilities where we're just keeping that same PureWick device in place. I wouldn't be surprised if eventually we'd come out with some better protocols of when those need to be replaced and cleaned up. So, sorry about that. Husband walked in. So I wouldn't be surprised if that when we are dealing with a lot of these PureWick devices, if we don't maybe have some better protocols in place of how often we need to get those changed. I just definitely see having that there can obviously be a major risk for fungal infections or any type of infection, honestly. If we're using that same PureWick thing several hours in the same place, I definitely can see that becoming an issue over time. Okay, on to head lice. So pediculosis is another obviously common skin ailment. This is on page 1619. As you guys can see, the best way I can describe how it looks in person is it looks like these little white things on the hair follicles, but they won't move. That's the best way to describe it. So you might think, oh, is that dandruff? And then you're like, oh, no, that's not dandruff. You can actually see, depending on how bad the infestation is, you can actually see the lice themselves. But these, of course, are the little nits or eggs, however you want to describe them. And they do attach to the hairs, and they do not come off. So that's when we do have to use special shampoos, usually they're like a wire type comb. I think I've seen some plastic combs now that we have to comb those nits out. I've only had to deal with this a few times in my area, the few times I've worked in pediatric areas. So it can be common, obviously, in school settings, daycare settings. I just remember, even with my kids, every now and then you'd get a letter coming home from daycare saying there was a kid that had lice in their thing. So just be aware. For the most part, I would feel like everything is so available over the counter now. I wouldn't be surprised if it's not as noticeable. And I even think my half sister, when I was in college, ended up getting lice. I cannot remember where. I think she went to some kind of camp of some kind. They were sharing combs, hairbrushes, things like that, and then ended up getting lice from something. And then my parents had to, they lived in Houston. My dad lives in Houston with my half sister. So he actually took her to a special place that is their specialty, is just dealing with head lice. And they shampooed her, got all the lice out, and then my parents just had to clean up her room and things like that. So our biggest thing when we are talking about head lice is obviously education, making sure that we are following the physician's orders or the instructions on the shampoos or lotions to remove the lice, as well as making sure that they understand you have to comb out all of those little nits. So obviously lice is an infestation of lice or parasitic insects that live in that scalp or hair. It can spread through close contact, sharing of hats, brushes, etc. Some of those signs and symptoms is that pruritus, so is that itchy scalp, red bumps, presence of lice or nits. And then our interventions do include administering and prescribe that pesticidal shampoos or lotions, creams, for the MD orders. I think most of this stuff is available over the counter nowadays. Instruct the patient and family on the proper application of the pesticidal treatment and emphasize the importance of combing out those nits. Oftentimes with those shampoos, especially the over-counter ones, I do know that they do recommend checking the individual's hair or scalp 5 days after you did the first round, and often they do need another round of treatments between that 7 and 10 day mark as well. It's just that life cycle of that lice is sometimes they don't get every egg or every nit, and then so that's why they've got to go back in about 5 to 7 days and do another treatment again to get that final bit that's left there. We obviously have to treat anything that fabric-wise that came in contact with that individual, washing bed linens, clothing, combs, brushes, stuffed animals, etc. Okay, so let's dive into your exemplars. That does include the pressure injuries. This does begin on page 1665. This is exemplar 21B. So what is a pressure injury exactly? A pressure injury is an ischemic lesion of the skin and underlying tissue caused by external pressure. As the pressure continues, it impairs our blood flow to that area, leading to necrosis of the surrounding tissue and ulceration. So obviously pressure injuries can appear on any part of our body depending on the pressure or how the person is obviously positioned. But it can also occur from friction, rubbing, shearing forces, and then obviously our bony prominences are where we definitely see or where we notice it the most and are concerned about that tissue. So high incidence, of course, is in hospital settings, long-term care facilities, and even a home setting. If you've got someone that is really not very mobile, they can get those bed sores and pressure ulcers. It's not just a hospital-acquired thing or a nursing home-acquired thing. So this is often due to immobility, inadequate nutrition, or hypoproteinemia. This is just the lack of protein in our diet. And just keep remembering, we really need that protein for healing. And then if they have like some chronic bowel or bladder incontinence issues, diminished sensations, or if you even have an individual that has altered mental status, maybe they're not aware that something's feeling numb and that they need to change their position. And so if they're just staying or laying in a certain spot over time, that of course is putting them at risk. And then those with advanced age, chronic health conditions, or those like a quadriplegic or some kind of trauma patient. Some other things to note down in your little note section underneath here. I want you guys to be aware Geriatric populations are at significant risk due to their loss of lean body mass. They do have that thinning of the epidermis or that atrophy of their skin. They obviously have some decreased muscle and elasticity of the skin. They have diminished venous or arterial blood flow. And then they can often have that dry, increased risk for dryness as well. So any kind of irritant can also makes that skin more susceptible to these pressure injuries. Other factors do include poor lifting or transferring individuals in the bed. That is more that shearing forces that we unfortunately can cause an individual. And then hard surface, not having proper supported surfaces, and incorrect application of pressure relieving devices. I know we had a patient up on, I can't remember if it was 4 North or 4 South, that ended up having some pressure injuries due to the wraps on his legs. And so we can, unfortunately, TED hose, things like that are important to use to prevent blood clots or to help with their venous circulation. Unfortunately, if they're put on improperly, if they're folding them down, if there's a huge wrinkle that is staying in that place over days and days, obviously that can lead to a pressure injury as well. Any kind of wraps too. I'm thinking about like Coban, Ace wraps, anything like that. If we are putting them on too tight or not putting it on them correctly and causing wrinkles in that material, we can cause a pressure injury as well. So here's a quick little video on basically pressure injuries themselves.
In Module 2, we will review how pressure injuries develop. The rationale on pressure injury development has evolved. While ischemia, or inadequate blood supply, plays a role, we now know the primary driver for pressure injury is soft tissue deformation. Direct damage from sustained deformation can result in cell damage in a matter of minutes. How do pressure injuries develop? They're caused by a combination of mechanical forces, pressure, friction, and shear. Let's explore this in more detail, starting with pressure. As mentioned earlier, when soft tissues are subjected to prolonged pressure over a bony prominence and another surface, like a bed or medical device, that's pressure. Friction occurs when two surfaces rub against one another. Have you ever experienced rug burn from sliding across carpet? That's friction. Shear happens when unaligned forces push part of the body in one direction and another part of the body in the opposite direction. Imagine going down a playground slide on a hot summer day, and your skin sticks to the slide halfway down, stopping your motion. Your skeleton is still being propelled downward, but your skin stays in the same spot. That's shear. Now, think about a patient sliding down in a hospital bed. There's friction from their skin rubbing repeatedly against their clothing and/or bed sheets. And there's shear at the interface between their skin and a bony prominence as they slide down. While friction affects the surface of the skin, shear affects the tissues deep within the skin, leading to tissue breakdown that can ultimately lead to a pressure injury. Moisture, which may include sweat, urine, feces, or excessive wound exudate, is another component of pressure injury risk. When the skin is wet, the stratum corneum, or outermost layer of the skin, becomes weaker and more susceptible to damage. Moisture can also exacerbate the damage done by friction, as it creates more drag between patient's skin and the fabric of their gown and bed sheets. Microclimate is the word that may be unfamiliar to you, but it is important. Microclimate refers to the temperature, humidity, and airflow next to the surface of the skin. With an increase in temperature and humidity, the skin becomes weaker, and there is an increased risk of friction at the surface of the skin. So imagine a patient sitting on a plastic incontinence pad, the warmth and moisture trapped between the surfaces of the skin and the pad. Any friction in this area will increase the patient's risk for pressure injury. So where should you look for pressure injuries? As mentioned, Pressure injuries can occur on nearly any location on the body, but there are some areas that are more vulnerable than others. For patients in the supine position, at-risk areas include heels, sacral, coccygeal area, elbows, shoulders, and head. For patients in the ICU, spending extended time in the prone position, attention should be focused on feet, knees, groin, hip bones, elbows, chin, nose, and forehead. Thank you for watching Module 2, where we discussed how pressure injuries develop. We hope you will join us for the next module.
Okay, so this 3M, obviously, this came from their advertisement for their pressure injury devices and bandages that they have available. You can actually Google this. They have several. Actually, you can just find these all on YouTube. But if you're wanting just a little bit more, or to kind of find about their product, of course, you can look up this 3M pressure injury education. They have several little short videos. They're about 5 minutes a piece. I'm not going to make you guys watch all of them, but I'm hoping for the most part that this video helped you visually be able to see what we're talking about when we were talking about that shearing forces and then that friction. And then, of course, even thinking about the whole bed situation often with our hospitalized patients when we've got the incontinent pads or leaking of fluids, anything like that, that's just going to make everything more susceptible to these pressure injuries. And so it's really about preventing this from happening, of course. So with our prevention, the biggest thing for preventing our bed sores is we do have to do something called a Braden scale. That is on page 1673. That is an example of a Braden scale. Every facility will have their own little version of that Braden scale, but the lower the number, the greater the risk you are to develop a bed sore or pressure injury. And then, of course, the higher the number, that means you are less at risk. So it just depends if you're bony, if you've had weight loss. There's several different criteria. I would make sure to review that chart and be familiar, so that way if it is discussed in a scenario on your test, you won't be completely thrown off. Just at least know those main categories: that sensory perception, moisture, activity, mobility, nutrition, and then that friction and the shearing risk. And then obviously know, I'm not going to make you memorize the numbers, but definitely know that the lower the number, you're at greater risk. And then, of course, you add all those scores up. And depending on that, there are certain protocols that facilities or units put in place for that lets them know, okay, you have to turn this patient every 1 to 2 hours. But really, in all honesty, especially with evidence-based practice now, they're not even trying to put a number on it anymore. They just say turn the patient when that patient needs to be turned. So if you've got somebody really immobile, ICU, on ventilators that can't do anything for themselves, they, of course, are having to change that, or not change, but reposition that patient sometimes every 30 minutes to an hour. Or if you have maybe just a weaker individual, like on a med-surg floor, he's able to somewhat shift around in the bed himself, but he can't roll. Maybe those are the individuals that we can put him on the two-hour turn schedule. So every facility will do this differently. So there's, of course, protocols you guys will learn when you guys get out and start working. Reposition, of course, with that pressure injury. If the individual is able to shift positions on their own, we will definitely encourage them to do that about every 15 to 30 minutes. That's what we're supposed to do with you guys, even in class. And I'm really bad about telling you all you can take breaks. So you guys probably already aware by now that I'm bad about that. So definitely don't be afraid to raise your hand and say, we need a break, Miss Bennett, because I know those chairs are not comfortable. So like I was saying, so otherwise, when we have protocols in place, for example, we've got to turn them at minimum every 2 hours or as needed per their condition. Those COVID patients that we had that were in the prone position that we actually had to put on their stomachs to help with that, with their respiratory system, those individuals, there were certain protocols. Gosh, and I can't even remember how long we flipped them for. I want to say it was for 4 hours. Yes, maybe it was longer. I can't remember. Sorry, but it's either 4 to 8 hours. We flipped them on their stomachs, and then we, of course, had to find out the hard way that bony areas, like our kneecaps, things like that, even like collarbone areas on some individuals, we didn't realize that was an issue with pressure injuries because they're all on their prone position. So they had to end up taking like heel protectors, things like that, and coccyx pads, things like that, and actually cut them to fit certain things. But I think now they have actually come out with actual things to put on those prone patients that fit like the kneecaps much better, things like that. But they were kind of MacGyvering it those early months of COVID, especially when they had a lot of those ICU patients in those prone positions. So obviously we need to avoid trauma. They are recommending now that the head of the bed is no greater than 30 degrees, if at all possible. Now, this may not apply to all patients or all situations. If you've got somebody on a tube feeding and you need their head of the bed up more, that's obviously important during that period when they're getting their tube feedings. But when we're able to, they are recommending now that we keep that head of the bed lower, so that way we're not causing that shifting or the pull of their weight in causing that patient to slide down the bed, just to kind of help with the shearing injuries, as well as sometimes what we end up doing as nurses is we may have their head of their bed up, but we're going to also elevate their feet, and then all that pressure is going into that coccyx area. So we just definitely have to be careful how we're positioning them, not keeping them in the same area, in the same position over and over and over several hours. They obviously have some assistive devices. Those of you that got to walk up to the rehab unit, we got to see the one that they use to help individuals with the zero gravity. And then, of course, there are the lifts, trapeze devices that help with moving patients up in bed. Nutrition, again, is huge. We obviously need that protein, iron, zinc, vitamins. We need to monitor weight loss if we're seeing excessive amounts. We need to start consulting maybe dietitian, nutritionist, and maybe let the physician know so that way they can look into nutritional aspects, maybe run some albumin, some labs, things like that. Obviously, hygiene is huge. We need to avoid extreme water temperatures, either not making sure that whatever water we are using to bathe the patients, that it's not excessively hot, because that can lead to burning or dry skin, as well as too cold of water as well can be irritating. Moisturizing lotions, barrier creams are often recommended for certain individuals, but not petroleum based. And then supportive devices such as specialized beds, mattresses, pillows, heel protectors, and specialized dressings. So there are 4 stages, actually 5 if you consider the unstageable one. So there are 5 stages of pressure injuries. This does have some charts and some images starting on page 1668 through 1670. I will also provide you guys a handout in class because we're going to dive a little bit deeper into pressure injuries, and I'll have you guys actually make your own little models of some pressure injuries. So stage 1 is usually non-blanchable. It is usually, we will notice that erythema or redness of the intact skin. Often we can just put some barrier ointment on there. I always think of like diaper cream as a good barrier ointment. And then some individuals, we can just put like that clear Tegaderm on them. Of course, some facilities now recommend you guys putting certain patches, and we'll show you guys some of those patches on Monday, putting those on like the coccyx areas, things like that. If you already know that an individual is bony, almost like a preventative. Now, stage 2 is when we get a little bit deeper into those layers of the skin. It is partial thickness. So remember that partial thickness is that first, about first layer and a half. It does involve that dermis. If there is minimal drainage, sometimes we just only need like a Tegaderm or some type of covering. Now, as the degree of damage happens, there can be some moderate to heavy drainage, and that those dressings that contain elegant hydrocolloid or the foam dressings are often recommended at that point. And then stage 3 is the full thickness skin loss. So that is all through those deep layers. We've passed that sub-Q tissue, that fatty layer, and now we are approaching that adipose tissue area. So adipose tissue is often very visible. There can be necrotic areas to this. So you can have necrotic tissue in stage 3, 4, and unstageable areas. So definitely keep that in mind. As you guys are learning these descriptions, you will have to know these. So I might describe a wound on the test, and you might have to tell me, is that a stage 1, 2, 3, 4, or is it unstageable? So definitely be aware of those. So the stage 4 ulcer is a full thickness skin loss as well. It is very extensive though. The damage is deeper into the fascia, muscle, tendons, ligaments, cartilage, and bone is visible. Often these require hydrogen gel, pads, alginate foam dressings as well. Forgot to talk about that wound packing with stage 3, often because there is so much drainage, we have to sometimes pack these as well. Both of these we can use those wound vacs for, honestly, and we'll go over that in just a little bit more detail on some wound vac things. But an unstageable wound means that there's been some there that we can't quite see deep into the pressure injury. So what's happened is there is eschar present, and we're unable to assess the depth or underlying tunneling. And so this means that we've got to remove that material on the skin so that way we can see, is it truly a stage 3? Is it a stage 4? So if slough or eschar obscures the extent of the tissue loss, this is an unstageable pressure injury, and it can be a stage 3 or 4 at this point. With the stage, you can have necrotic tissue with stage 3 and 4 as well, depending on the depth of the injury. The extent of damage cannot be determined due to necrotic tissue often, and so this does have to often be removed. If necrotic tissue is present, it is usually unstageable until surgical debridement happens to reveal the depth of the injury. So just be aware of that. Some other notes underneath your slide here. Another category that they often will talk about when we're talking about the stages of wounds is something called a deep tissue pressure injury. This is a persistent, non-blanchable, deep red, maroon, purple, discolored area. The best way I can describe it is it looks like on a individual has light skin, it looks like almost like a really bad bruise, but the damage is actually so deep. It's not a bruise. It's much more extensive. The necrotic tissue can form in that subcutaneous area. There can be some granulation tissue, which is actually a good thing. There can be damage through to the fascia, muscle, or other underlying structures are visible. This indicates a full thickness pressure injury. It is often unstageable, an unstageable 3 or an unstageable 4, and suspected deep tissue injuries is often very difficult to detect in dark-skinned patients. So you may have that necrotic tissue where we're not being able to see clearly because of how deep that injury has occurred. So how do we deal with some of these? We can obviously put special dressings on them, but surgically we can do something called debridement if the pressure ulcer is deep, if there's subcutaneous tissue involved, and then if the eschar has formed over that ulcer, we do have to remove it. There's also something called autolytic debridement. Is an alternative. It's alternative to surgical, medical, enzymatic debridement. It uses the body's own enzymes to break down the necrotic tissue. It does take longer, but causes less damage to the surrounding tissue as the body heals. There is a larva therapy. We can use that through fly larvae or maggots that do these maggots digest the enzymes. Let me start this over again. So when we're using those maggots on the skin, is their digestive enzymes from the maggots themselves help break down the necrotic tissue. They also secrete antimicrobial compounds, and then the movement themselves from the maggots on the skin can stimulate granulation. And then, of course, with some individuals, depending on how bad the injury to their skin is, they can do skin grafting. Okay, diving just a little bit deeper into wound healing. This is exemplar 21.C. This does begin on page 1679 through 1687. There are obviously three types of what we call intention. So we have the primary intention. This is this first example up here. This first, I guess you'd call level of wound healing. So primary intention is that that first healing process, the tissue surfaces have been approximated. That means they are closing up with little or to no loss of other tissue area, formation of minimal granulation tissue, and scarring. So as you can see, the pictures obviously will probably be a lot better inside your book, but as you can see, as this incision, because it's we're not worried about infection, anything like that, we've got a nice clean incision. We get it closed early enough, and then we will usually have hopefully a minimal scar. So think of somebody cutting themselves, them getting stitches immediately, and then hopefully we have that minimal scar afterwards. Now, secondary intention, this means that the wound is much bigger, and the tissue loss and edges are not usually well approximated. So this can be this is usually more traumatic injury. As you can see, the edges are not nice. This isn't like a clean cut from something. This is obviously more of a traumatic injury. As you can see, the edges are not nice and even, and so this will take a lot longer to heal. But as this does start to heal, it will go into what we call that primary intention, where the edges will, like I was telling you guys, it's going to start healing from the inside out. And so as that granulation tissue starts filling up this gap, it's going to help bring those edges to close. And then unfortunately, the scar is much bigger than if we could have closed it nice and beautiful. Then we have our tertiary intention. This is our delayed primary intention healing, where we often have to keep that wound left open for sometimes 3 to 5 days or maybe even a week. And this does allow swelling or the infection to be resolved. This is often those patients that we do have a wound vac for. So we have to usually sometimes pack these wounds, use a wound vac, things like that. And it's that same process. It's going to heal from the inside out. We're going to see that granulation tissue start growing and filling in this gap. And then eventually maybe they have to do some kind of suture or something to actually get it to close completely. These patients for sure have to have some kind of wound vac. So let's look into a little bit deeper dive into the phases of wound healing. The biggest thing I want you guys to get from this particular section of the book is being able sorry, lost connection there. The biggest thing I want you guys to get from this slide and from this area of the book is to be able to recognize when we're using wound scenarios on your tests will describe a healing process of a wound or skin, be able to recognize what is actually something good that's happening. Just know that granulation tissue is actually a really good thing. It is often a red tissue. It can be very flat, fragile. It can bleed easily, but this usually is a sign of healing. We need that granulation tissue to hopefully heal whatever injury has occurred, and so definitely keep that in mind. So first, we will usually have that inflammatory phase. This is often those first couple of days following an injury. Homeostasis happens, vasoconstriction to cut off that. Our body will try to decrease the blood flow temporarily, obviously, to keep the injury from bleeding. Fibrin will develop as well as blood clots, and then a scab will usually form. Phagocytes, this is our white blood cell counts. do increase, and then the macrophages take over, and that's when our immune system is hopefully taking over, fighting against any germs or bacteria that might be present. And then the proliferative phase, this is roughly around 3 to 5 days, but it can progress all the way up to 21 days. This is when the fibroblasts synthesize collagen and fibrin start to develop, and then our capillaries do start to increase the blood supply to that area. This is when that granulation tissue often forms. And so this, as you guys can see some of these dates, so when I think of, sorry about that, surgical patients, that 2-week window is so huge right here. So for incisions, things like that to heal, those individuals are so at risk for things not healing correctly, and how important those first 21 days or 2-week time period is all this first stages of healing. And then how well is our body going to adapt to that? Is our white blood cells going to help fight off anything? Or are we going to have that granulation tissue start forming? Is our blood supply going to hopefully be well enough that it's getting good circulation back to that area? And then the maturation phase, this is greater than that 21 time period, 21-day time period. This can be often up to 1 to 2 years depending on where the injury is and the healing of that. Fibroblasts continue to synthesize collagen. This is, of course, when the scars truly form. You can actually have, during this phase, if there's an abnormal amount of collagen that forms, we can get the keloid hypertrophy, where there's significant scars that end up developing. Sometimes, depending on where those are located, plastic surgeons, things like that, sometimes have to go in and get those cleaned up, depending on the individual and where it's located. But the biggest key I want you guys to take away is, as you can see, this first 2 weeks or that 21-day time period is huge. But as you can see, the healing process is still pretty significant. Depending on where it is, it can sometimes take several years to be completely healed. I don't know if you guys have ever had surgery of any kind, but I would say this is definitely very true. I'm just thinking of like my C-section scars. I would say that first 2 weeks, definitely, that's when you're kind of making sure everything's looking good, nice and clean, staying, the skin is intact, everything, the closure is happening in the area, and there are edges of the incisions are hopefully healing well, and then we're hopefully avoiding any type of infection. And then over time, over these 1 to 2 years, that is when that scar starts to form from that collagen and then the fibroblasts. So some of the complicated wounds I want you guys to definitely be aware of is obviously when we have a wound infection. So this middle picture of this guy's arm or wrist, you guys can see how inflamed that is, how much swelling. If you guys can see just on the top of his hand and knuckles area, how huge that wrist probably really is in real life. Definitely some major inflammation here. This does not look good at all. Definitely want you guys to be aware of those drains, and then just definitely keeping an eye on those dressings. How often are they getting changed? When does the physician want them changed? Things like that. And then the other big words or vocabulary words you guys need to know is this word dehiscence. This is actually when a wound pops open, or an incision can pop open. So I always think of just like this letter D here, all this stuff is staying inside, so nothing's pouring out of the wound. It's just that the sutures have popped open, or the incision itself has opened up. Now, evisceration means that the wound has not only opened up, but the insides of that wound has come out. So if it's on the abdomen, you may have colon or intestines that have fallen out. It just depends on where actually the incision was, and then what material is actually coming out of that incision. So that's just some couple of examples. Definitely surgical wounds are huge. We have to really watch these. Watch for this. If it is an evisceration, that is an emergency situation. I'll go over that here in just a second. And it does require us to alert the surgeon immediately. So, some things to watch for. Obviously, we watch for bleeding. We watch for massive bleeding. We are looking for that hematoma, especially like I was saying, after certain procedures, if they've gone through arteries, anything like that. We look for that internal hemorrhage. People are mostly at risk during that first 48 hours after surgery. or if there was some sort of trauma or emergency. Massive bleeding obviously is emergency, and those people need to seek out emergency care immediately if we're having concerns about uncontrolled bleeding. There is obviously our risk of infection. So this is obviously from contamination of the wound surface with microorganisms. This, unfortunately, we don't live in sterile environment, so this is really hard for us to stay away from every sort of germ that's out there. But we do obviously really try to educate our patients. Proper hand washing, making sure to keep things clean, not reusing the same bandage, all those type of things. Changing bandages when needed, keeping things dry and intact at all possible. So the presence can impair wound healing, presence of bacteria or microorganisms can obviously impair the wound healing, leads to infection. Immunocompromised patients are especially susceptible. Our elderly population, HIV patients, the NICU babies, any of those type of population areas. When the wound does become infected at the time of injury, a wound can become infected at any time. At the time of the injury itself, during surgery, or even post-operatively, because of those 2 to 11 days post-operative period. And that goes back to this slide when we're talking about this proliferation phase. So that is when we're really concerned about that 10-day mark after surgery. That's when that 2-week period. That's why we have to have you guys come, or patients need to come back in to see us after 2 weeks after surgery, for that very reason. So then the dehiscence with possible evisceration. So remember, dehiscence is partial or total rupture of the suture of the wound. It just means that it's opened, that incision got popped open. Now, evisceration, on the other hand, is the protrusion of internal organs, I'm just thinking of like intestines, things like that coming through. So risk factors do include obesity, poor nutrition, multiple trauma, failure of the suture. So maybe the surgeon didn't do a good job suturing, or maybe sutures were too tight and they broke or ripped. And then excessive coughing, excessive vomiting, or even just dehydration, because obviously dehydration will cause our skin to be over dry, and that can interfere with the healing process as well. They will often have a sudden straining episode, and then possibly that dehiscence will happen first, and then maybe the evisceration will happen because the dehiscence happened. When this happens, this is an emergency issue. You need to cover that dressing. Don't use a dry gauze. We have to soak it in sterile water. I'll explain a little story. My mom is a nurse, so I'll explain a little story about the first time she had to deal with a patient with evisceration, what she did wrong, and then what the surgeon made her do. So I'll tell you guys that on Monday. But definitely something that I learned from her story, so I definitely know you have to soak that sterile gauze before you actually cover whatever's protruding out of that incision. Oh, we have to obviously notify that physician immediately. Okay, so our role when we are talking about wound care, wound assessments, all of this, our role is obviously to document. This is just a summary. We're going to document those characteristics: location, size, depth, color, drainage. We're going to assess for potential delays in healing. Do they have any underlying conditions? Diabetes, anemia, steroid use, nutrition deficits? Are they elderly or have a weak immune system? Some interventions. Can we protect their skin in any way? Is it something like diaper ointment, barrier cream, anything like that? Would that help? Can we treat it with antibiotics, wound care teams? Is there excessive amount of drainage? Do we need a JP drain? Do we need a wound vac to help as well with more of a chronic issue? And then nutritional support. And then dressings, of course. Incisions or lacerations usually only need dressings temporarily until bleeding subsides or drainage subsides. And then usually surgeons won't want that covered the whole time. And then, of course, you have your regular other wounds. There are so many different protocols out now, and for the most part, I know at least at Northwest, when we're talking about a significant wound, it almost seems like they get a wound care team on it. But we do have wet to dry dressings, and then wounds need to be clean and have some sort of moisture. We often have to have some moisture to help that healing process. We just don't want it to be excessive moisture. Here is an example of wet to dry dressing that some of you guys might get to actually see.
Showing you how to do just a standard wet to dry style dressing or Aquacel dressing. Most of these are going to be found on the wound protocols, which print off on every patient admitted by the hospitalist, so that way you have all your orders for simple wound care. So we're going to start with cleaning the wound. You can either clean the wound with a wound cleanser such as this, and just squirt the wound and then pat it dry with gauze, or you can clean it with saline, and this is going to be the preferred method if you're taking a wound culture, because the wound cleanser will contaminate the wound culture. So if you're planning on getting a wound culture, then clean it with the normal saline and some gauze. And if you are irrigating, if you've got a larger wound that has some eschar or slough or some debris, or it may just be easier for the patient if they're having a lot of pain, you can actually get a 60 cc lure locked syringe and put a 16 or an 18 gauge Gelco on the end, draw it up with some normal saline, and then start from the top of the wound and irrigate down. Like if the patient was on their side, it would be this way. Like if they were laying on their side, whichever side of the wound is up, you're going to be irrigating top to bottom, and that way all the drainage and the debris and the infection rolls out of the wound. So that's how you do the irrigation. Now to do a normal saline style gauze dressing, you're just going to take a little bit of some gauze out of one of the packages, just enough to be able to fill the wound, fill in all the dead space up to the wound level itself. Put a little saline, just enough to where you can wring it out. I usually either wring it out over like the trash can, or one of these little tub trays is perfect, just enough to where you can wring it out. Okay, and then you're going to take your gloved fingers and you're going to fluff it out. Okay. And then you're going to take your little Q-tip and fill in all the dead space. So we're going to start with this little divot here, and then just fill it in, and you may have to cut a little bit of it off. And this one we are going to cut off a little bit because, again, like I said, you want it to be just to where you can fill in the wound. You don't want to overstuff it and overpack it. And then you can cover the top of it with either some dry gauze or an ABD pad, depending on how much it's draining, and then secure it with some tape or any type of a cover dressing to keep it airtight and waterproof. If you're doing a different type of a packing, like an Aquacel, if you've got like a chronic wound that you want to kind of help to keep moist, this is a good dressing right here. Good primary dressing. You can either...
Sorry, her video cuts off, but here is the second part of her explaining that.
Aquacel, again, you can use it dry by just putting it into a wound, and the wound drainage is going to wet it. And that way it'll keep the wound itself moist and the skin around it dry. If you've got a dry wound and you want to pre-moisten it, you can take some saline, and this Aquacel will literally turn into a gel. Okay? And that way you can pack that in, and that can be your wound filler. Okay? And again, just fill in all the dead space just to the skin level and don't overpack it. And then you can cover it with your secondary dressings, just like you did with your wet to dries. Either some gauze or ABD, or if you can cover it with one of our Sacral Heart dressings. Again, always date, time, and initial your dressings.
Okay, so that is just a quick example of what we call a wet to dry dressing, or when we're even having to pack those wounds a little bit. And then this other slide is actually an example of a wound vac. So for wound vacs wound vacs do help heal impaired skin that is not properly healing properly, or there is concern of how deep and tunneling that might be occurring. So that's why we usually like a stage 3 or 4 ulcer, those type of things. That's when we do get concerned, and then we bring this in to help heal the wound from the inside out. So obviously we use these vacuum assisted devices after traditional therapies have failed, or if the wound is too large. This is also used on a variety of types. Oh my gosh, there are so many different sizes of these sponges. You can actually even cut them to fit the actual wound itself, depending on where that incision or wound is that is not healing well. They've really come a long, long way since when I first started. It is important to note that for some wounds that we do not want, we should not use a wound vac on wounds that contain eschar, necrotic tissue, or malignancy present. We have to remove all that before we can actually get down to where the healthy tissue is. We have to get down to that part or that surface of the skin. If we are just putting this on top of a wound that maybe has that eschar or necrotic tissue, it's not going to help anything. We've got to get that removed usually ahead of time, usually with some sort of debridement, and then the physicians will at that point let us use the wound vac. We can't obviously use these wound vacs if there is an open vessel, because it is applying pressure and you can actually just keep making that vessel bleed. So if you ever have a patient that has a wound vac and you notice they're having bleeding, you may let the physician know, and they may have to take a look at that a lot closer and see, is there a vessel that's maybe oozing, something like that, that we may at this point not be able to use the wound vac. I think that's kind of similar to what happened with that patient that was up on 4 North. It was obviously she was having some underlying issues, and then they were trying to use that wound vac on top of it, and it just made the problem worse. We also can't use the wound vac if there's exposed nerves, other organs, as well as there it goes, or individuals that have osteomyelitis. We can't use it, but once we've started the antibiotics and they've been on the antibiotics for the osteomyelitis, we can use the wound vac. So definitely keep this criteria in mind.
When managing a wound using 3M vac therapy, the proprietary 3M vac granufoam dressing, which is a reticulated open cell.
So as you can see, we cut these, which I'll explain this Monday a little bit better. We actually cut these foam to fit the wound itself exactly. So that's it's going to kind of skip over that part. But in the real world, we actually usually have to cut these to fit that exact wound. So just like the other picture where she was saying we don't want to put too much of that gauze, it's the same thing. We don't want to overfill these wounds. It needs to be almost exactly the shape of the wound the sponge does.
Foam is placed directly into the wound bed. A semi-permeable drape is then used to seal the wound, provide a moist wound environment, and protect the wound from external contamination. The proprietary 3M sensor track pad and tubing are then applied to the drape and provide the connection to the therapy unit. 3M sensor track technology helps provide uniform negative pressure to the wound surface. It also provides alarms when there are conditions that would impact negative pressure wound therapy. The application of uniform negative pressure when delivered by 3M vac therapy applies mechanical forces, macrostrain and microstrain, that together removes exudate and infectious material, reduces edema, and promotes perfusion, creating an environment conducive to the formation of granulation tissue. Macrostrain is the physical response that can be seen immediately as the wound edges are drawn together, thereby ensuring that there is optimal contact between the wound bed and the 3M vac granufoam dressing. Macrostrain facilitates removal of wound exudate, which may contain inhibitors of wound healing. Removal of wound fluids assists in the reduction of edema, which facilitates the flow of blood into the wound bed, providing the oxygen and nutrients that are needed for wound healing. The biological responses are initiated as an effect of microstrain, which results from the manifolding of negative pressure across the proprietary 3M vac granifoam dressing to the wound surface. This creates areas of cell surface strain, also called microdeformation. Tissue microdeformation at the cellular level leads to cell stretch. When cells of any kind are stretched, they are stimulated to expand, become thicker and more metabolically active. This response to cell stretching has been well documented and is clinically used. For example, when tissue expanders are applied to stimulate the formation of new skin. In vitro and in vivo studies conducted using negative pressure have shown that these activities include increased metabolic activity, fibroblast migration, cellular proliferation, and extracellular matrix production. All of this activity leads to the formation of healthy granulation tissue in the wound bed, and the characteristic undulations that have been seen in wounds managed with 3M vac therapy. Over subsequent dressing changes, the granulation tissue fills the wound bed, further reducing the wound volume and preparing it for final closure by secondary or delayed primary intention.
Okay, so as you can see that it is a lengthy process, honestly, with those wound vacs. It's not overnight. It usually does take several weeks for them to get to that point where it is that granulation tissue is spread up to the surface, so that way it can eventually close. So one other thing I want to talk to you guys real quick about before I finish this slide here, or this VidGrid, is just obviously our risk for patients of getting hospital-acquired infections. MRSA, VRE, that is huge issues. Staph infections are huge in the hospital setting. The best thing I could say to you guys to just obviously educate ourselves and educate our patients and families is prevention. We need to proper hand washing. Of course, those that worked with me at Northwest, were some of those students were able to work with the Nosen nasal swabs. They use those to hopefully, not all patients are prescribed them, but some of the patients, the physicians are kind of catching on to using those. But it is a nasal swab. It's called a Nosen nasal sanitizer. It is an antiseptic that is used to kill pathogens, bacteria that is carried through our nares or nasal area. Our sinuses are often the reservoir for antibiotic-resistant susceptible staph aureus, like MRSA or MSSA on the body, and it also harbors other microbial pathogens. And so I was explaining that nasal swab to my students, and even the patients will tell you, it's got some essential oils in there to make it comfortable, because it basically is essentially an alcohol wipe that we're using to kind of on the inside of their nasal area. We're swabbing it, and then it is a citrusy, almost like orange smell to it, and so most patients don't complain about using it. They can often honestly do it themselves. We just usually scan it, and then we hand it to them, and then they take care of it. But obviously contact precautions are huge. So when we do identify a patient that maybe has those microorganisms growing either in their sinuses or in a wound, they're put on contact precautions to protect our other patients, and then of course proper hand hygiene.
On any given day, about 1 in 25 hospital patients have an infection caused by their medical care. Almost half of these patients are 65 or older. There are 5 places where patients are most likely to get infections: in the bloodstream, the urinary tract, the gut, and the 2 most common places are the site of surgery and the lungs. The germs most likely to cause healthcare-associated infections include C. difficile or deadly diarrhea, staph, including the drug-resistant type known as MRSA, a family of germs known as Enterobacteriaceae that includes CRE, the nightmare bacteria, Enterococcus, which can be resistant to an important antibiotic, vancomycin, and Pseudomonas, which can cause infections of the lungs and bloodstream. 1 in every 9 patients who gets an infection will die during their hospitalization. Over the last several years, great progress has been made in preventing some infections. For example, bloodstream infections in patients with central lines have been nearly cut in half in the last 5 years. But more work needs to be done. CDC's goal is to eliminate all healthcare-associated infections. We work 24/7 to save lives and protect people.
Okay, so just a good reminder for you guys, just to be aware of those infections and definitely follow protocols when we are dealing with contact precautions. So I hope this was helpful for you guys, and I will look forward to seeing you guys on Monday, diving a little bit deeper into some wound care information, and we will probably take a little quiz when we start out our class, and then we will dive into some more hands-on material.